Mucosal melanoma, breakthrough script. Most cancers get easier to treat the further you catch them. Melanoma works backwards. The skin kind, the kind dermatologists catch early, responds beautifully to newer immunotherapies. But mucosal melanoma, the kind that grows inside your mouth or on your mucous membranes where nobody's looking until it's massive, practically ignores those same drugs. So a team in China tried something wild. What if you hit it with two drugs at once, drugs that are supposed to work through completely different mechanisms? And the results were strange enough that it raises a question nobody really expected to ask. Are we treating cancer at the cellular level when we should be thinking about it more like plumbing? Here's what everyone thought they understood about melanoma treatment. The revolution in cancer drugs over the last 15 years came from immunotherapy, basically teaching your immune system to see cancer cells as the enemy and attack them. It works phenomenally well for melanomas that happen on skin exposed to the sun. Dermatologists catch those, patients get treated, and survival rates skyrocket. But mucosal melanomas are different creatures entirely. They grow inside the body, in places like the mouth, throat, sinuses, or urinary tract. By the time someone finds them, they're already aggressive. And weirdly, those same immunotherapy drugs that work so well on skin melanoma barely budge mucosal cases. It's like finding a key that opens 90% of locks, then handing it to someone whose door uses a completely different mechanism. For years, oncologists have been stuck asking, if immunotherapy isn't the answer, what is? This study comes from Zhang and colleagues at the affiliated cancer hospital of Zhengzhou University in China, published in Frontiers in Immunology in 2026. The team is distributed across 3 institutions, with researchers in radiation oncology and immunotherapy in Zhengzhou, and precision health specialists contributing from Michigan State. This is the kind of international collaboration that feels increasingly standard in oncology. A disease doesn't care about borders, and neither do the best research teams anymore. The work was registered as a formal clinical trial, which matters. We're not talking about a small observational study here, but a structured phase 2 trial with proper ethics approval and all the formalities. So here's what they actually did. Between June 2019 and December 2022, they enrolled patients with advanced mucosal melanoma who'd already failed previous treatments. These aren't early-stage cases. These are people who've already tried other options and watched them not work. The researchers gave every patient a combination of 2 drugs. The first is SHR-1210, which is a checkpoint inhibitor. It basically removes the brakes that cancer cells put on your immune system. The second is apatinib, which does something completely different. It blocks blood vessel growth. Think of it like this. If cancer is a city, SHR-1210 is telling the police force to finally arrest the criminals, while apatinib is cutting off the supply roads. You're not just attacking the cancer directly, you're attacking the infrastructure it needs to survive. They gave patients 200 milligrams of SHR-1210 intravenously every 3 weeks, combined with apatinib, and then they watched what happened. The study continued collecting data until June 2025, giving them real-world results across multiple years of treatment. Here's where it gets interesting. The combination actually worked. In patients with BRAF-negative mucosal melanoma, that's about 80% of mucosal cases, the overall response rate was meaningful. Without getting lost in percentages, let's say a significant chunk of patients saw their tumors shrink or stop growing. That might not sound revolutionary until you remember that these are patients who'd already failed other treatments. This is last-line therapy. These are people who are running out of options. More importantly, the researchers found that the combinations seem to work better than either drug alone might have, which suggests there's something about using both simultaneously that creates a genuine advantage. It's not just additive, it's synergistic. But here's the honest part. Side effects were real. Immunotherapy comes with the risk of autoimmune complications. Your immune system doesn't just attack cancer, it can start attacking your own tissues. Apatinib adds its own toxicity profile on top. Patients experienced fatigue, which is extremely common. Some had blood pressure issues because you're blocking blood vessel growth, and your blood vessels do things you kind of need them to do. A few patients had more serious complications. This wasn't a magic bullet. It was a genuine trade-off where you're accepting real toxicity in exchange for a chance at tumor control. What this actually means in practice is that mucosal melanoma patients, a group that's been largely underserved by modern oncology, might have a new option. If you have late-stage mucosal melanoma and standard immunotherapy hasn't worked, this combination might be worth discussing with your oncologist. But this doesn't change how you prevent melanoma. Sun protection still matters infinitely more than any treatment ever will. What it does change is the conversation for someone already in this terrible situation. The bigger implication is more intriguing. Traditional thinking says you should find the right single mechanism and exploit it. Precision medicine, the idea of tailoring treatment to individual biology, has usually meant finding the specific mutation driving someone's cancer and hitting that target. But this study suggests something different. Maybe some cancers respond better when you attack multiple systems simultaneously. Maybe the reason mucosal melanoma was resistant to checkpoint inhibitors isn't because patients' immune systems are fundamentally broken. Maybe it's partly because the tumor's blood supply is unusually robust, or the tumor microenvironment is fundamentally different. You can't recruit immune cells to a tumor if they can't get there. You can't get them there if the blood vessel network is blocked. This raises a genuinely important question for cancer research going forward. Are we overthinking precision at the genetic level while missing precision at the systems level? Should we be doing more research combining immunotherapy with anti-angiogenic drugs in other cancer types? The field has been somewhat siloed, with immunotherapy teams and drug development teams not always talking closely enough. Studies like this one suggest maybe they should be. Future research should probably look at whether this combination works in other hard-to-treat mucosal cancers. Does it help with mucosal head and neck cancers or uveal melanoma? Should we be doing randomized trials comparing this combination to standard therapy in first-line treatment rather than just late-line? And can we figure out which patients will respond best before starting treatment, rather than discovering it through trial and error? Turns out, when one door closes, sometimes the solution isn't finding a better key. Sometimes it's knocking down the wall while simultaneously cutting off the building's power supply. For mucosal melanoma patients, this combination therapy might be exactly that hybrid approach. The real question now is why nobody thought to combine these drugs sooner, and what other cancer combinations we're still missing. Turns out, scientists have been busy, and they're not done yet.